Rheumatic fever is a traditional favorite that usually shows up in some way on step 1 because it combines immunology, micro, and pathology. Before we even start, let's take a second to make some things clear. There is a big difference between scarlet fever and rheumatic fever, but both can be a potential consequence of streptococcal pharyngitis. So scarlet fever is named scarlet fever because these patients turn scarlet red, like the color of my pen ink. This is a hypersensitivity reaction to the group A strep's toxin. The toxin is called erythrogenic because it makes the patient very erythematous, hence erythrogenic. That means that the kid had to be infected once for initial exposure to this toxin, then they were infected again and the immune system reacted to seeing the toxin one more time. Scarlet fever usually shows itself in a kid with a strawberry tongue with red, blanchable, sandpaper-like rash. And where does this rash start? It starts on the head and the neck, and it spreads everywhere. But, very important, once this rash starts to desquamate, it is not going to involve the soles or the palms. Now, on the other hand, this acute rheumatic fever is completely different. It's mediated by molecular mimicry. The immune system creates an antibody against a component of the group A strep that's incredibly similar to some of our own tissues. Unfortunately, these antibodies not only bind the group A strep, but they also bind to our own tissues. And this usually takes 4 weeks to happen. After the initial infection, because the body has to process the group A antigens and then make antibodies. This patient will present with the classic Jones criteria. This is described as a migratory polyarthritis affecting many joints and changing where it occurs, a carditis or inflammation of the heart, subcutaneous nodules, erythema marginatum, which is a very unique skin finding, and Sydenham chorea. This is how you're going to be able to diagnose the process that's going on. But the questions will probably include some of the microbiology or pathophysiology behind this disease. So let's talk a little bit about Streptococcus pyogenes. There are many virulence factors that contribute to the pathogenesis of this disease. For example, this bacteria produces streptolysin. This is an exotoxin that binds to cholesterol within cell membranes of red blood cells, neutrophils, and platelets. And it can cause these cells to lyse because water will enter them and cause them to explode. Now our body is going to produce antibodies against this toxin, and we look for it to help us in the diagnosis. And this is anti-streptolysin antibodies. That's a great way for them to tie in diagnosis with microbiology. Now this bug also produces streptokinase. Streptokinase is very important because it activates plasminogen and makes plasmin. It also produces one more thing, and that's hyaluronidase. Hyaluronidase is an important enzyme which allows bacteria to spread by breaking apart hyaluronic acid. Hyaluronic acid is an important component of connective tissue. This is a great time to flash back to your immunology. Now, what is the protein present in group A Streptococcus pyogenes that our immune system will produce antibodies to that can cross-react with our antigens? This is M protein. The M protein shares epitopes, or pieces of amino acid sequences, with myosin. The antibodies produced against M protein cross-react due to the molecular mimicry with the myosin that we see in the heart. Now the antibodies bind to myosin, creating myocarditis. This is the myocarditis component of the Jones criteria. Another polysaccharide component of the group A strep can cause cross-reactivity with glycosaminoglycans that are present in our connective tissue. Sounds like a pretty bad thing to make antibodies that can end up binding myosin of cardiac tissue and glycosaminoglycans that are on things like heart valves. You better believe this is a bad situation. That's why streptococcal pharyngitis is kind of a big deal, and you need to treat this with penicillin as soon as you suspect it. Now, what else can these antibodies bind? Well, a carbohydrate antigen of the bacteria shares a very similar structure with gangliosides that we see in the brain. Now, what kind of symptoms will you see if we are depositing antibodies into our brain, particularly in places like the basal ganglia? We're going to see chorea. Chorea is Greek for dancing. Someone with chorea looks like they have uncontrolled dancing movements because of inflammation in the basal ganglia. It's called Sydenham chorea because that's the place in England where it was first identified as part of this disease. Now you have to understand that there is a 10 to 20 year difference between some of the symptoms that can appear from the acute phase of being infected with group A strep compared to the late stuff or the late sequelae such as valvular stenosis and fibrosis. The initial damage to the mitral valve causes mitral valve regurgitation, but the resolution with fibrosis and calcification leads to mitral valve stenosis. much later on in the person's life. Now, despite knowing all of this information, we can still get an image like this and be expected to know what's going on. We need to be able to understand and recognize what we see on microscopy and relate it back to the disease. So what are we looking at? These are Aschoff bodies. These are granulomatous nodules within the heart composed of concentrations of lymphocytes, plasma cells, and a bunch of abnormal macrophages called Anichkow cells. We can see those here in this image. The Anichkow cells are enlarged macrophages with condensed chromatin. This condensed chromatin makes them look like caterpillars. If these macrophages or Anichkow cells fuse together, because that's what macrophages can do in a state of chronic inflammation, we get Aschoff cells. Note how they are very large and very dense looking. When these combination of things are in a conglomerate, we call them an Aschoff body. So don't worry about these eponyms. No way they're ever going to be used again. Understand how these things are going to be described to you. You need to know how they will describe these findings.